Okay, let's think about something really common, a medical challenge that,
Yeah.
well, it touches millions of lives every year. Pneumonia.
Right. We all know the name.
Exactly.
Hmm?
But how do doctors actually make those um, incredibly precise decisions when it comes to treatment, especially when every single patient is different?
It's complex.
Welcome to the deep dive. Today, we're taking a really close look at community-acquired pneumonia, CAP for short.
Hmm.
And our mission, really, is to understand how clinicians figure out the best initial treatments and, just as vital, when it's actually safe to stop the antibiotics.
Yeah, that stopping point is key.
We're going to unpack the nuanced why behind these choices, based on specific patient stuff and the latest clinical guidelines.
And our sources for this, they're really insightful. They come from detailed medical practice scenarios.
Oh, interesting.
Yeah, so it gives us a window into the actual critical thinking needed for, optimal patient care.
It's like looking over their shoulder almost.
Kind of, yeah. It's the decision-making process in action.
Absolutely. So this deep dive, it's really your shortcut to being genuinely well-informed about a vital area of healthcare. We're not just looking at the right answers, but the fascinating reasons behind them. And what happens when patient factors throw a curveball into the standard plan.
Those curveballs are where it gets really interesting.
Let's get started then. So our first scenario, it brings us a 68-year-old man.
Okay.
He's got a history of high blood pressure, type 2 diabetes, but they're well controlled.
Good.
He comes into the hospital, fever, cough with mucus, shortness of breath, going on about 3 days.
Classic pneumonia symptoms.
Right. Chest x-ray shows an infection, left lower lung. So he needs to be hospitalized,
Makes sense.
but not critically ill, so no ICU needed.
Yeah.
And crucially, no known risk factors for those really tough bugs, like MRSA or Pseudomonas.
Okay, that's important context. No suspicion of multi-drug resistance.
So for the medical team right then, the immediate question is, what?
What's the best initial antibiotic regimen? Right away, before we know the specific bacteria causing it.
Right, the empiric treatment.
Exactly. Based on the most likely culprits given the situation.
And what's the recommended approach for this patient, given those specifics?
The guidance here, it's pretty clear. A combination. Ceftriaxone plus azithromycin.
Okay, ceftriaxone plus azithromycin. That sounds like a solid combination. What's the core thinking? Why that pair?
Well, for these hospitalized CAP patients, the ones without suspicion of resistant bugs, the sources really strongly recommend starting with combination therapy.
Okay.
It's generally preferred over using just one single strong antibiotic, like, say, a respiratory fluoroquinolone.
Even if that single drug might seem effective on its own.
Yeah, even then, the combination gives you broader, more sort of strategic coverage right out of the gate.
So it's not just about raw power, it's about the right kind of coverage.
Precisely. The preferred combo uses an anti-pneumococcal beta-lactam ceftriaxone in this case, which hits bacterial cell walls hard, paired with a macrolide, like azithromycin, which stops bacteria making proteins.
Different mechanisms.
Exactly. And there are a couple of really critical reasons for this choice. First, all hospitalized CIP patients need coverage for what we call atypical pathogens.
Atypical pathogens, like what?
Things like Mycoplasma pneumonia, Chlamydia pneumonia, Legionella species.
Ah, Legionnaire's disease, right.
Right. And these can cause severe pneumonia, but clinically you often can't tell them apart from other types at first glance. Macrolides, like azithromycin, are essential for covering those guys.
So even if the patient looks like they have classic bacterial pneumonia, you're saying there's no way to be sure initially if these atypicals are involved.
They're not without specific tests, which take time, so you need that comprehensive coverage up front.
Okay.
But here's another interesting layer. A lot of observational studies actually suggest that combining a beta-lactam with a macrolide is linked to better outcomes, especially in severe CAP.
Better outcomes. Why?
Well, the thinking is it's possibly due to the immunomodulatory effects of macrolides.
Modulatory?
Immunomodulatory, meaning the drugs aren't just killing bacteria, they might also be helping the body's own immune response.
How so?
Like maybe reducing inflammation in the lungs, that kind of thing. It's a potential added benefit.
Huh. That's fascinating. An antibiotic doing more than just killing bugs?
Mm-hmm.
And what about the risks? You mentioned avoiding single agents sometimes.
Right. The sources also point to concerns about potential side effects and antibiotic resistance.
Like C. diff.
Exactly. The risk for Clostridioides difficile infection, that nasty gut infection, and also the risk of selecting for resistance in other bacteria just hanging out in the body. Those risks are generally thought to be greater with fluoroquinolones compared to this preferred beta-lactam plus macrolide combination.
So it's also about trying to minimize that collateral damage.
Absolutely, both for the patient and, for public health, thinking about resistance.
Okay, so using a single drug like levofloxacin, a fluoroquinolone, it is an option, but maybe not the first choice here.
Correct. An alternative if the preferred combo isn't possible, but not the top pick.
And just ceftriaxone alone, not enough.
Nope, that would miss the crucial atypical coverage we talked about.
What about going really broad, like piperacillin tazobactam plus vancomycin?
Whoa, way too much firepower for this patient. That's reserved for when you have a really strong suspicion of MRSA and Pseudomonas. Serious overkill here.
Got it. And doxycycline by itself?
Also not ideal. Doesn't provide broad enough coverage for the common typical bacteria like strep pneumonia. Its main role, actually, as we'll see,
Foreshadowing.
is as an alternative to a macrolide, but in combination with another antibiotic.
Which brings us perfectly to our next case. This is where those patient-specific factors really, really change everything. Let's think about a new patient. 55-year-old woman, also admitted for CAP, but she has a critical medical history.
Okay, what is it?
Prolonged QT syndrome. And she's currently taking amiodarone for atrial fibrillation.
Ooh, okay. Prolonged QT and amiodarone, that's a significant flag.
Right. But again, no MRSA or Pseudomonas risk factors suspected.
So the core question is the same. What's the best initial empiric antibiotic for her? But that history, that completely changes the standard playbook.
And the recommended approach here, according to the sources.
Look, is ceftriaxone plus doxycycline.
Doxycycline.
Yes.
So that's where it comes in. This really highlights how individual patient factors are just paramount.
They absolutely are. Her history of prolonged QT syndrome, that's an electrical issue with the heart rhythm, can lead to dangerous arrhythmias.
Right.
And her use of amiodarone, which is a heart medication that also prolongs the QT interval.
Those are the critical pieces here.
Why are they so critical for the antibiotic choice?
Because both macrolides, like the azithromycin we just favored, and fluoroquinolone antibiotics, like levofloxacin, can also prolong the QT interval.
So they pile on the risk.
Exactly. They can potentially push someone into a life-threatening heart rhythm called torsades de pointe. It's a major drug safety concern. You absolutely want to avoid that if you can. So the drugs that are normally preferred or strong alternatives suddenly become problematic for this specific patient.
Correct.
So how does doxycycline provide the solution here?
Well, this is where the guidelines get specific for this risk group. For patients at high risk of QT interval prolongation, the sources explicitly prefer doxycycline as the alternative to a macrolide.
And the key reason is?
Crucially, doxycycline has not been associated with QT interval prolongation.
Okay, so it avoids that specific risk.
Precisely. So the ceftriaxone plus doxycycline combination gives you the necessary beta-lactam coverage for the common typical bugs, plus the atypical coverage from doxycycline, all while completely avoiding that QT prolongation risk you'd get with azithromycin or levofloxacin.
That is a perfect example of personalized medicine right there.
Yeah.
Tailoring the standard approach based on individual risk.
It really is.
So levofloxacin monotherapy, maybe an alternative sometimes, but definitely out here because the QT risk.
Correct. Should be avoided.
And the standard ceftriaxone plus azithromycin, normally preferred, is unsuitable because of that azithromycin QT risk in this patient.
You got it. And just using other beta-lactams alone, like ertapenem or ampicillin-sulbactam.
Still wouldn't cover the atypicals.
Exactly. Still lacks that vital atypical coverage needed for anyone hospitalized with CAP. It just really underscores how that individual patient profile has to guide every single decision.
Okay, so we've covered starting strong, and we've covered customizing treatment based on risk. But what about the other end? The crucial art of knowing when to stop.
Yes. Antibiotic stewardship. Hugely important.
Right. So our final scenario, 72-year-old woman. She was hospitalized for severe CAP.
Severe CAP, okay.
Started on IV ceftriaxone and azithromycin. Now, after 5 full days of treatment, here's her status. She's been without fever for 60 hours.
Good sign.
Breathing comfortably, no supplemental oxygen needed, and she doesn't have any underlying lung disease that would require it normally.
Also good.
Vital signs are stable. Heart rate 88, respiratory rate 20, blood pressure 120 systolic. No other signs of clinical instability.
Checking all the boxes so far.
And one more piece. Her procalcitonin level, that blood test that helps track bacterial infection activity, has decreased significantly.
Okay, that adds to the picture.
So the core question now is, when is it appropriate to stop her antibiotics? This really tests our understanding of the right duration.
Absolutely. How long is long enough?
And based on the sources, what's the verdict for her right now?
Antibiotics can be discontinued now?
Now, after just 5 days, even though it was severe initially?
Yes, provided she maintains this clinical stability.
Okay, that's a clear guideline. What are the specific criteria that let us make that call?
So what's really important to remember is that patients with CIP should generally be treated for a minimum of 5 days. That's the floor.
Minimum 5 days, got it.
But before stopping, they have to meet very specific clinical stability criteria. Let's break them down.
Please do.
First, they need to be febrile, no fever for 48 to 72 hours. Our patient is at 60 hours.
Check. Meets that one.
Second, breathing comfortably without supplemental O2 unless it's needed for a pre-existing condition.
She meets that too.
And third, they should have no more than one clinical instability factor. And those factors are defined pretty clearly. Heart rate over 100 beats per minute.
Hers is 88.
Respiratory rate over 24 breaths per minute.
Hers is 20.
And systolic blood pressure less than or equal to 90 mmHg.
Hers is 120. So she has 0 instability factors.
Exactly. 0 is definitely not more than 1, so she meets all the criteria.
Wow. Okay, so she hits all the marks. Even though her illness started out severe, she's met these stability criteria after 5 days.
Precisely. And most patients actually become clinically stable within about 3 to 4 days. So for good clinical responders, the recommended total duration is usually in that 5 to 7 day range.
Not 10 days, not 2 weeks necessarily.
Not unless there are complications. This case is a perfect example of why antimicrobial stewardship is so important. We want to avoid unnecessary antibiotic exposure once stability is achieved.
Because more isn't always better.
Definitely not. It can lead to increased antibiotic resistance down the line, more side effects for the patient. If they're stable and meet the criteria, stopping is often the right move.
So the idea of continuing antibiotics until her chest x-ray looks completely clear, that would be wrong.
Yes, that's a really common misconception. X-ray improvement often lags way behind how the patient actually feels and looks clinically. It can take weeks, even months, for the X-ray to fully clear up.
Wow, months.
Yeah, so you definitely don't continue antibiotics based solely on the imaging. Clinical stability is the key.
And what about that old idea of treating for a minimum of, say, 10 to 14 days? Is that just outdated now for most CIP?
Largely, yes, for uncomplicated CIP. Multiple big studies, meta-analyses have actually supported these shorter 5 to 7 day regimens.
What did they find?
They showed no significant difference in clinical cure rates or relapse rates compared to longer durations. And interestingly, maybe even lower mortality and serious adverse events with the shorter courses.
Fewer side effects, maybe?
That's likely part of it. Longer durations are really only reserved now for specific complicated situations, like if you isolate Pseudomonas, or if there's necrotizing pneumonia, empyema, infection spreading outside the lungs, or maybe if the initial therapy just wasn't working well.
But none of that applies to our patient here.
Correct, none of it.
And even the fact that she had severe CIP initially doesn't automatically lock her into a longer course.
Not once she meets those clinical stability criteria. The severity at the start doesn't mandate a longer duration if she responds well and stabilizes according to the guidelines. The sources just don't support longer courses for severe CIP without those specific complicating factors.
Okay. And one last thing, that procalcitonin level, it went down, which is good, but do we need to wait until it's, like, undetectable?
No, not necessarily. Procalcitonin can be a helpful guide in the decision to stop. Especially when a patient looks stable, it adds confidence. But it's not the sole determinant. Clinical improvement meeting those stability criteria we discussed, that remains paramount. Waiting until it's undetectable isn't really a standard criterion in isolation.
Okay, that really clarifies the stopping criteria. So we've taken quite a fascinating deep dive today into community-acquired pneumonia.
We really have.
We've learned how those initial antibiotic choices are so meticulously tailored to each patient, right? Balancing that need for broad coverage against individual risks, like that QT prolongation issue.
Yeah, the personalization is key.
And we've also seen just how critically important it is to know when to stop the therapy, guided by these really precise clinical criteria, not just some arbitrary number of days.
That stewardship piece is vital, using antibiotics wisely.
This isn't just about, memorizing medical facts. It feels like it's more about appreciating the incredible precision and, frankly, the critical thinking involved in modern medicine.
It really is. It shows how every patient's unique story, their specific circumstances, dictates their treatment plan. A one-size-fits-all approach just doesn't cut it.
So thinking about all this, What does it mean for you, listening? Maybe consider this. How might understanding this intricate dance, this balance between a patient's existing conditions and the latest treatment guidelines, how might that inspire you to think differently about the really personalized nature of healthcare?
Or even the broader implications, like antibiotic stewardship, not just for individuals, but for all of us globally.
Right. Maybe it highlights that even in situations that seem straightforward on the surface, like treating pneumonia, there's always this deeper layer of complexity, this careful calculation that's worth exploring. What other surprising connections might exist in areas you're curious about?